Our first speaker is Dr. Anand Baharani, sir. Please welcome Dr. Anand Baharani on the stage. For this session, the topic is accelerated hypertension, and our chairpersons are Dr. Neeraj Jain. Dr. Neeraj Jain, please welcome. You are welcome on the stage. Please. And Dr. Ashish Rawat. Dr. Ashish Rawat is with us. I would like to welcome our both chairperson, Dr. Neeraj Jain and Ashish Rawat. I want to welcome you. Dr. Rahul Shukla sir is requested to welcome our both chairperson, Dr. Neeraj Jain and Dr. Ashish Rawat. Dr. Pawan Sthapak sir is requested to welcome our speaker, Dr. Anand Baharani. Please. Dr. Anand Baharani is MD Medicine and DNB Nephrology.
Good morning, everyone, respected senior and dear colleagues. To begin with the first scientific session, our esteemed speaker is Dr. Anand Baharani. He is a consultant nephrologist and renal transplant physician. He did his MBBS from KIMS Bangalore and MD from Aurobindo Indore. He acquired his super specialization at Krishna Institute of Medical Sciences, Hyderabad. He has been a member of various associations and he has many publications in the index journal to his repute. The topic today chosen is in accelerated hypertension. We all know that it's a silent killer and almost 2/3 of the population is unaware of their hypertension status. And of them, almost 2/3 are not being properly treated. Even if they receive treatment, most of them are not achieving their target blood pressure. So it is a serious issue which should be addressed. And I invite Dr. Anand Baharani to kindly enlighten us on this particular issue, especially the uncontrolled or the accelerated hypertension. Thank you. Over to you, Anand.
Good morning, judges and respected members of the IMA, the organizing committee. Thank you, Neeraj sir, Dr. Pawan Sthapak sir, Dr. Sangeeta ma'am, Dr. Padman Swami sir for giving me the opportunity. Thank you, Ashish sir, for chairing the session. Today we are going to discuss about accelerated hypertension. If you all give me permission, I would like to start the session. We have all seen our patients, the fewer case scenarios we are going to discuss and how we are going to manage those patients in the later slides we will discuss. 25-year-old male with no previous comorbidities came with complaints of headache, blurring of vision. On an investigation, was found to have elevated blood pressure of 220/100. Serum creatinine was elevated and was found to be 9.4 mg per day. His hemoglobin was 6.4. Ultrasound was suggestive of bilaterally contracted kidneys, and all this was favoring the diagnosis of CKD. How would you manage this patient in your clinical practice? These are a few slides of case scenarios which I would like to discuss, and then we will discuss how we will manage these patients. And we can have an interactive session in the end if anybody wants to answer these questions. Case scenario 2, we have a 65-year-old male with hypertensive, diabetes, and a history of headache, blurring of vision, one episode of seizure and loss of consciousness. CT brain was suggestive of intracranial hemorrhage. How would you manage this patient? In the scenario 3, we have a 55-year-old male who's a smoker with accelerated hypertension and diabetes. came with BP of 90 by 100 with the ST elevated, changes in injury leads, and elevated cardiac biomarkers. The patient was diagnosed with acute anterior wall MI. How would you manage this patient? We will discuss about the hypertension, the following contents: the introduction, the classification, and the hypertensive crisis, the diagnosis, and the management. First, about the introduction: rapid increase in blood pressure sets a vicious cycle consisting of blood vessel wall stretch, activation of RAS system, endothelial dysfunction and damage, and microthrombi formation, which leads to end organ damage of the brain, heart, kidneys, and may be irreversibly damaged. The renal damage and excessive hypertension: these patients who present with excessive hypertension, they have a CKD issue in 8.4 to 31%, AKI in 20 to 55%, and those who are requiring renal replacement therapy, they are about 6.6 to 13%. Morbidity and mortality rates are higher in these patients. Death was attributed to anemia in 50 to 60% of these patients. In one of the case series, partial renal recovery was seen in some, and some had rapidly progression to the ESRD. Classification of hypertension, as we already know: essential hypertension and secondary hypertension. Essential, in which we don't know the cause, seen about 90-95% of the cases. Secondary hypertension, in which there is a specific cause and seen about 5 to 10% of the cases. The various other types of hypertension are levite hypertension, isolated diastolic hypertension, isolated systolic hypertension, malignant or accelerated hypertension, refractory resistant hypertension, hypertensive emergency, and emergency. Coming on to today's topic, we have hypertensive crisis. When some patients come with severe hypertension, we should look for target organ damage, whether he is having any neuroretinopathy changes or any surgical situations. If these are present, then he will be having a hypertensive crisis. And if neuroretinopathy changes are present, we should suspect that he is having a malignant hypertension. The differences between accelerated hypertension and malignant hypertension: in malignant hypertension, we have encephalopathy, nephropathy, and accompanying papillary edema. Patient will have fundus showing papillary edema, and target organ damage will be seen in eyes, heart, lungs, and kidneys. There will be fibrinoid necrosis, which is not present in accelerated hypertension. The patient will be also having microangiopathic hemolytic anemia, and systolic and diastolic blood pressure will be usually greater than 40 and 120. In accelerated hypertension, there is no such demarcation, and there is no microangiopathic hemolytic anemia in these patients. Hypertensive emergencies, as we all know, there are various things: cardiovascular conditions, acute myocardial infarction, ventricular failure, aortic dissection. Renal conditions like RPG and renal vascular hypertension, renal crisis, and systemic sclerosis. Severe hypertension after kidney transplantation. Neurological conditions like hypertensive encephalopathy, intracerebral hemorrhage, subarachnoid hemorrhage, cerebral embolism, and acute head trauma. These all patients we have seen in our clinical practice and will be seen regularly. Those patients who are having a catecholamine excess, pheochromocytoma, interactions with dioxin containing foods, and those who are on various drugs, use symptomatic drugs, and pregnancy-related complications, the eclampsia. Some of the surgical conditions which we will see usually CABG patients will be having excessive hypertension, and those patients who have severe burns will also have hypertension. The etiology of malignant hypertension: the main etiology is medical non-compliance. We write so many medications to the patient will not understand and will not take medications and will not come to us for follow-up also. Renovascular hypertension: those patients who are having renal artery stenosis, polyarteritis nodosa, Takayasu arthritis. Renal mesenchymal disease like glomerulonephritis, tubular interstitial nephritis, systemic sclerosis, HUS, and SLE. Endocrine dysfunction: those who are having pheochromocytoma, Cushing's, primary hyperaldosteronism, renin-secreting tumor, these all will be having hypertension. Coarctation drugs like cocaine, phencyclidine, sympathomimetics, cyclosporine, Fosiclis. These patients can also have malignant hypertension. Those patients who have recently taken ACE inhibitors also can present with excessive hypertension if they are having renal artery stenosis. Antihypertensive medication withdrawal, amphetamines, and CNS system disorders, those who have head injury, cerebral infarction, cerebral hemorrhage. The pathophysiology of malignant hypertension: severe uncontrolled hypertension can lead to pressure-induced radiations, which leads to RAS activation and lead to microcirculatory damage. There is increase in the renal vascular resistance, and there is autoregulation failure. All these will coincide and cause target organ damage. Complications which we will see in excessive hypertension are encephalopathy, intracerebral hemorrhage, myocardial infarction, heart failure, pulmonary edema, unstable angina, dissecting aneurysm, AKI, and legionnaires. How will we diagnose these patients? First, we will take a clinical history of these patients and we will ask whether he is having any headache, nausea, vomiting, visual disturbances, dyspnea, orthopnea. We will review his all medications, whether he has taken his antihypertensive drugs or not. We'll check about any recreational drug use or amphetamines, cocaine, or OCP drug use. Physical examinations, we should confirm the BP in all limbs with an appropriate sized cup. Taking medications, measuring BP is very important in our clinical practice. We should make the patient calm, set him in OPD for about 10 to 15 minutes, then recheck his BP again and confirm after reading of 15 minutes or something. Then we should diagnose him not on the first reading. Fundus examination should be done, as we all know about the Keith-Wegener staging, which is of hypertensive retinopathy, which shows hemorrhages, X-rays, and rapid decline grade 3 and grade 4, which are features of malignant hypertension. We should look for signs of heart failure, the murmurs and the gallops, pulmonary edema, abdominal bruit in cases of renal artery stenosis, neurological findings like stupor, seizures, delirium, and agitation. The evaluation should be based on the different organs involved, and if the patient is having an ocular system involvement, we should go for fundoscopy. Cardiovascular involvement, we should go for ECG, chest X-ray, cardiac enzymes, CT angio of the chest and abdomen if we are suspecting aortic dissection. CNS system examination, if the patient is having hypertensive encephalopathy, CEA or breast, we should go for a non-contrast CT or an MRI. The patient is having renal dysfunction, renal failure with microangiopathic hemolytic anemia, we should go for urine analysis, basic metabolic panel, LDH, hepatic and indirect. Coming on to the management, it is a interdisciplinary approach where we should take help of internists, nephrologists, cardiologists, and neurologists. All should be involved in the management of these patients. So coming out, we should not reduce the BP too fast and too much. That is the key to take home. Within the first hour, we should reduce the BP by 10 to 20% and by another 5 to 15% over the next 24 hours. If we reduce the BP too fast and too much, the patient will have a CVA, which will be because of the reduced perfusion to the brain. There is often targets in a target BP of less than 180 by 120 for the first hour and less than 160 by 110 for the next 24 hours, but rarely less than 130 during that time frame. As per the treatment management given by the 2017 ACC guidelines, the patient is having a BP of more than 180 and 120, 120, we should look for target organ damage. If there is no target organ damage, we can manage on OPD basis. We can give him increase his oral antihypertensive and send him home and watch for his antihypertensive, watch for his blood pressure and ask for a regular follow-up. If the patient is having any hypertensive emergency, we should look for aortic dissection, severe preeclampsia, pneumocytoma. Any of these conditions are there, then acutely BP has to reduce to less than 140 over 120 if the case is of aortic dissection. If these are not there, then maximum we should go over is about 25% in the first hour and gradually going to 160 over 100 over the next 2 to 6 hours. IV drugs which we should use for the treatment of hypertensive emergencies, the CCBs, nicardipine, clomipene, vasodilators, nitric oxide dependent, sodium nitroprusside, nitroglycerin, vasodilators, hydrolysine. We should all take care about sodium nitroprusside has a tachyphylaxis associated with it. Beta-adrenergic blockers, we should use esmolol, which can be used. We should monitor for bradycardia and it may worsen heart failure. Labetalol is mostly used in pregnancy-induced hypertension. Phentolamine can also be used in patients who are having pheochromocytoma and interactions between monoamine oxidase inhibitors with food, cocaine toxicity, or amphetamine overdose. Enolodopam can be used and enalapril can be used. Enalapril should remember that enalapril is contained in pregnancy and acute MI in those patients who are having bilateral renal artery stenosis. It is mainly helpful in hypertensive emergency when there is high plasma renal activity. So coming out to the basic 3 questions which we asked in the beginning, how to manage those 3 kind of patients, this will be dealt with in these slides. Patients with coronary ischemia, we should go ahead with nitroglycerin, nicardipine, and second line we should use nitroprusside and esmolol if patient heart failure is absent. Heart failure, we should treat nitroglycerin, sodium nitroprusside. Renal dysfunction, if patient is having renal dysfunction, we should manage with enolodopam, nicardipine, labetalol, and diuretics we should use if the patient is having any fluid overdose. In scleroderma renal crisis, we all know we should use ACE inhibitors, enalapril is the drug of choice, and ARBs and phenolodopam can also be used. We should avoid diuretics and corticosteroids in scleroderma renal crisis. In patients with neurological conditions like hypertensive emergency, ischemic stroke, and interstitial hemorrhage, we should use nicardipine, labetalol, and nicardipine labetalol in interstitial hemorrhage. Nimodipine has also been used in subarachnoid hemorrhage to reduce the interstitial pressure and helps with that. Patients who are having catecholamine excess, we should use pentolamine for pheochromocytoma, and those who are having cocaine ingestion, we should use pentolamine or labetalol combination. And after coronary artery bypass surgery, post-operative, some patients can develop hypertension. We should use NTG or esmolol, labetalol in these patients as well. In pregnancy-related hypertension, this we have clinically seen so many times that we all know the answer. We should use labetalol, and second choice we should give nifedipine, nicardipine, MGS4, methyldopa, and hydralazine in these patients. Drugs which we should avoid in pregnancy are ACE inhibitors, ARBs, and nitroprusside. So coming on to the dialysis perspective of the patient. Sorry, I'll take just 2 minutes. Coming on to the antihypertensive drugs which we should use in dialysis, as we all know, patients who are on dialysis, some of the drugs are dialyzable and can be removed. Though in calcium channel blockers and ARBs can be used in those patients. Newer modalities for resistant hypertension, the renal denervation of sympathetic nerves is used, and baroreflex activation therapy, AV anastomosis and carotid body resection can be done in these patients. To summarize, I would like to say excessive hypertension continues to occur and associated with irreversible end-organ damage. The management requires an interprofessional team, interdisciplinary approach. Adequate therapy, including medication and target, BP target needs to be chosen wisely. Even after successful medical management, ongoing follow-up care is very much essential to reduce the risk of complications in these patients. Thank you for your patience. Anybody has any queries?
Thank you, Dr. Anand. It was really very wonderful and elaborative talk about the accelerated or malignant part of hypertension. All I want to say is, since we are dealing with this subset of patients, we should not forget just one thing to add on. I know it is difficult to cover in 15 minutes, but we should always look on the electrolytes, and if there is hypokalemia in spite of presence of significant hypertension, then primary aldosteronism or aldosteronism of any cause should be ruled out. So electrolytes also play a very important role. I can take 1 or 2 questions if anyone is interested. Sir.
Hello. Excellent presentation, Anand. You have covered most of the, in very short span of time, most of the things which we usually discuss in hypertension. Only few comments in our practice which I have observed that after complete workup of the hypertensive patients, we go on adding antihypertensive, even 3 drug, 4 drug, but in spite of that, blood pressure is not getting under control. And when we again look up in these patients, that sleep apnea syndrome is one of the very important cause, and which was not worked out initially. So we should look this sleep apnea syndrome, which is very common nowadays. And when we corrected this sleep apnea, then blood pressure automatically got controlled. And in fact, those patients, those who were needing 3, 4 drugs, suddenly came down to 2 drugs, and even 1 drug was sufficient to control the blood pressure.
Sir, very nice. Thank you, sir.
I think there are no other questions. So I would like to thank Dr. Anand Baharani for giving us a comprehensive, concise, and updated information on accelerated hypertension and sharing with us the prompt diagnosis and the accurate management. Thank you. Thank you all.
Thank you, Neeraj sir and Ashish sir.
I request Dr.